Good afternoon, everyone, and welcome to our webinar. My name is Trevor Timchak, and I'm with the Human Services and Justice Coordinating Committee. Today's webinar is on community crisis response teams, and we're going to begin, and we will end at 1 p.m. We'll have a question and answer period and general discussion at the end of the webinar, but please feel free to type in your questions into the chat. Or the Q&A box. And want to remind people that the webinar is being recorded, and the link for the recording as well as the slides will be uploaded to our website soon after the webinar, and you'll also be sent a link to it. We also want to recognize and value the diversity and backgrounds and opinions of the presenters and the webinar participants, and that disagreements and opposing views are seen as an opportunity for further discussion. Please treat the presenters and all webinar participants with courtesy and respect. And our webinar today is being presented by persons from Canadian Mental Health Association, British Columbia, as well as Canadian Mental Health Association, Toronto Branch. And we'll begin with our presenters from Canadian Mental Health Association, British Columbia, and I'll let them introduce themselves.
Thank you, Trevor. Hello, everyone. Happy to be here. Thanks for having us. So as Trevor mentioned, my name's Erin Ewart. I'm the Associate Director for Crisis Care Reform with the Canadian Mental Health Association BC Division. And before I introduce the rest of my team, I'd just like to respectfully acknowledge that our CMHA BC offices are located on traditional unceded lands of the Musqueam, Squamish, Tsleil-Waututh, Lekwungen, and WSÁNEĆ people throughout Vancouver and Victoria. So here with me, I have two of my three provincial managers working on the peer-assisted care teams in BC. So Sarah Potts, who you'll hear from in a little bit, who is the provincial manager for crisis reform policy and strategy, and Ebony Rosa, who's the provincial manager for community partnerships. Not able to join us today is also our third provincial manager, Alex Besson, who's the provincial manager for strategy and operations. So just a quick overview of what we're hoping to cover today in our time with you. This is the agenda that we have planned. We'd like to begin with a bit of a broad overview, looking at who CMHA BC is and the work we typically engage in, particularly with respect to our role in the administration of peer-assisted care teams, PACT, here in BC. Next, we'll move into an overview of the PACT model and how this model of mental health care and support fits into the current ecosystem of care in BC. The next part of the presentation will provide a brief background and timeline of PACT in BC and goes into more specifics around the operations of the teams. Lastly, we wanted to focus on reflections and learnings to date. We are still in the early stages, so we'll speak to how these reflections and learnings support ongoing plans for community engagement, evaluation, and expansion. So a little bit about CMHA BC. The Canadian Mental Health Association, CMHA, is a national charity that has been around for over 100 years that provides advocacy and resources working towards a vision of Canada where everyone can realize their human right to their best possible mental health. In BC, we operate with one provincial division where we're calling in from and 14 local branches. There's a map, a small map in the corner there, but you can see the dots of generally where we are in BC. CMHA BC is a leading mental health nonprofit organization providing mental health skills and resilience programs, delivering training and education, connecting individuals and organizations to resources, and advocating for mental health priorities for all British Columbians. CMHA BC's services and supports aim to prevent mental health problems, support recovery and resilience, and enable all individuals to flourish and thrive. BC Division has a history of system-level advocacy focused on policing, the broader justice system, and mental health. In a moment, Sarah will provide an overview of the PACT model, but we want to note that CMHA BC is leading the administration of this provincial initiative by building a network of community service providers to administer teams. We'll talk about them shortly here. CMHA BC is specifically responsible for selecting the service provider, implementing standards of practices, establishing best practices, training, advocacy, and monitoring and evaluation. PACT is definitely not a one-size-fits-all model here in BC, and it's important we take the time to understand each community's capacity, resources, and crisis care ecosystem. So I'll pass it over to you, Sarah.
Thank you so much, Erin. So I'm going to start us off here by kind of giving us a visual to frame up the peer-assisted care team model in BC. So this image illustrates where PACT is situated within the emergency responses to mental health crisis in BC. So PACT aims to introduce a mental health first response to mental health and substance use emergencies among the continuum of responses. So currently, community members can call or bystanders or service providers or individuals themselves can access PACT through a local 7-digit number. And so from there, highly skilled dispatch and access folks will assess the call and determine the appropriate steps for a response. And from there, we'll send out teams, and we'll get into that a little bit later. There is a great deal of support and movement towards including a fourth option in 911, which we currently don't have right now in BC. So instead of just police, fire, ambulance, mental health. And this represents a great deal of what's next for the evolution of this work in BC. Next slide, please. Thank you. So why this approach and why a community or a civilian-led team? Now, we all know, as we all know, in many jurisdictions in Canada, police services and emergency departments have become the default response to mental health crisis in our communities. And we know these systems are overwhelmed and are not intended to address many of the mental health and substance use crisis as they are, but due to legislation and a lack of voluntary health and social services, people experiencing crisis are often faced with responses or over responses that do not match their needs. These responses are resource intensive and can lead to undue harm to significant harm. In BC, unfortunately, involuntary apprehensions are steadily rising at approximately 30,000 a year. It suggests that there aren't enough voluntary health services available, particularly for community members in crisis. In general, across the board, there are a lack of community-based mental health services and interventions that are 24/7. They're voluntary, that include 48-hour follow-up, that do not require referral, do not require an individual to reach a specified acuity of risk to access, or do not involve police. And unlike co-response or CAR programs, as they're often referred to in BC, PACT is voluntary and does not include enforcement or detainment. There's no, PACT teams don't carry weapons, and there are no lights or sirens. And we know this as in some cases, individuals may feel unsafe calling first responders due to pre-existing trauma associated with police or hospital systems or previous criminal involvement. And we understand the arrival of an armed police officer for a health crisis adds a new energy to an already combustible situation. The choice of going to hospital here is the decision that rests with the individual and their support system. The team will provide information and support them if they decide that going to hospital is the right choice for them. Next slide, please. So, to many, the approach of PACT is new and even a bit confounding, but this idea isn't new at all. We are building on best practices from around the world, from Eugene to Portland, Denver, New Zealand, Sweden, and Toronto, where there are highly successful civilian-led models that are community-driven, person-centered, and responsive. So we get a lot of questions about what the team looks like and who is actually responding to calls. So our peer-assisted care teams that are dispatched are comprised of two trained individuals with experience providing culturally safe and trauma-informed responses to people experiencing mental health and or substance use crisis. Members of the teams are employees of the local community organizations that secure the RFP to deliver the service, and CMHA-BC provides provincial standards, trainings, policy, procedures, evaluation, and ongoing support. Team members are hired based on their experience and education, but all team members go through an extensive evidence-based training curriculum that prepares them to respond to various crises in their community. And some of that curriculum includes, but not all, standard first aid, cultural agility, mental health act training, violence prevention, assist, crisis de-escalation, understanding boundaries, understanding biases, injuries or physical or psychological causes for altered mental status, and the list goes on. And PACs also have access to the provincial peer support curriculum. So training is ongoing and iterative. Training opportunities are organized based on what teams are seeing on the ground and the complexities and challenges based in their communities. Paramount and of utmost important to us and to our teams is the physical and mental safety of the people folks that PAC teams are serving, and also PAC teams themselves. So part of this work is ensuring there's strict safety protocols in place, and teams have planned in place to protect and support the well-being and mental health of their staff and clients. And now I'll pass it on to Ebony for the next few slides.
Thanks, Sarah. So we just wanted to provide a quick overview of the history of PACT in BC, just to show how we've arrived at this point. So the first PACT team was actually a pilot that started in November of 2021. And what happened was with the CMHA, the Canadian Mental Health Association North and West Vancouver branch, during the pandemic, they hosted dialogues with staff and participants around equity and inclusion and identified a need to dive deeper in mental health and substance use crisis response, specifically for racialized and Indigenous communities. So they drew on their existing relationships to bring together a community planning table, asking follow-up questions about who needed to be represented and how best to support the involvement of folks with this engagement process. The table was co-hosted by the branch as well as the BC division, who was hoping to build on our existing work, looking at the intersections of policing and mental health and to respond to this crisis that's occurring across BC. And so their community engagement tables met monthly. They had local nations join in, representatives of first responder groups, people with lived and living experience, as well as independent municipal councillors, immigrant and refugee serving organizations, and interested community members. So before launching the pilot, they engaged in this extensive community engagement across the region and have continued to do so to help inform their work. And a lot of what they found out kind of led to the design of the initial pilot. Specifically, this team is available, offers services in 2 languages, both Farsi and English. All teams are available to any individuals 13 years of age and older. And they ensured that their services would be accessible by phone or by text. And just in the first year of service, this team received over 750 calls or texts during the first year of operations. So now just looking at the current teams, due to the success of the North Shores model, the provincial government provided funding in 2022 for the expansion of the North Shore team, as well as pilots in Victoria and New Westminster. So we can see that each of the teams is led by a different service provider, which is something that's really unique and helps inform kind of the supports and services that are offered both in individual communities as well as provincially, looking at some of our best practices. And so you can see here, we do have different hours with teams, but due to recent provincial funding, we're able to expand to a 24/7 model, which will be scaling up over the summer and moving to 24/7 in September. And in terms of the selection of service providers and implementation in these new communities, the process in New Westminster and Victoria did look a bit different. So the cities of Victoria and New West, due to municipal advocacy, work from councillors in the city, they put up their hands when there was a call to looking for new communities who would want to implement a pact. So now just looking more at some of the details, we've seen the big picture of PACT, but we'll just look at the actual response pathway. So to start, as Sarah mentioned, PACTs do employ a direct dispatch model, but work is underway to examine what is needed to be integrated within existing systems. So yourself, a family member or a community member can call or text your local PACT number. That's the first step. And then a member of the dispatch, the team will assess the situation, just ensuring that meets the call criteria. It's appropriate for the team to respond. And all three teams have done excellent jobs working within their communities to share about the PACT model and support understanding for community members, so that when they are experiencing a mental health or substance use crisis or see a community member in need, they do feel comfortable calling PACT. So once the situation has been assessed and a team member determines that PACT can respond, the two-person team that Sarah had briefly mentioned will go on the ground. And so not all teams or not all calls that a team receives will be dispatched, because as a result of the training, teams may be able to de-escalate a crisis over the phone. In fact, in the first few months since launching, the New West and Victoria teams responded to over 140 calls and provided in-person response to 84% of those calls. So when we're at the third stage here, when the team arrives on the scene with consent, because everything is consent-based, the person experiencing crisis will receive in-person support that is trauma-informed. There will be on-site assessment and continuing triaging of the situation. And the team may call 911 if appropriate. So they'll engage in safety planning, providing harm reduction services, navigation support, or any other type of support that's provided. And what's key to this model is the fifth stage here, where PACT does conduct a follow-up within 48 hours to connect the individual to any additional community services or provide any other follow-up with consent of the person. So now just looking at the types of calls that our teams respond to. So that includes anything from self-harm, suicidal ideation, escalated behavior, and disputes between two parties, a well-being check, substance use challenges, or any other mental health crisis, including loss of reality, anxiety, depression, panic, or anger. And so we wanted to just share a short testimonial from a service provider who called one of our PACT teams. And this client was demonstrating escalated behavior. They had a long history of brain injury, and that escalated behavior, they experienced a crisis. So this would have been this person's final chance to stay in their low barrier program. Given this person's history of escalation, there was little hope that they would be able to access any other services. So this service provider called the PACT team, and within 20 minutes, they had support for their client. The client left the shelter site and continued to escalate in public. The PACT team was able to support and assist the client in returning to the shelter with de-escalation in his behavior. So this care had a profound impact on the client being able to continue to participate in the long-term programming that was best able to meet their needs. And so I think that's just a really powerful story of what you can see when you're able to access a mental health response, a mental health first response versus the traditional responses that Sarah was talking about that we tend to see. And so just briefly, there's a lot of reflections and learnings as we've carried on that our team has talked about, and I just wanted to highlight these ones here. So the first is the importance of ongoing community engagement with diverse representation. So I talked about some of the engagement that our North and West Vancouver PACT team engaged in, but also the importance of carrying on that engagement kind of throughout the process to help inform the work that we're doing. So we've identified that further engagement in communities should require facilitated dialogues as well as one-on-one conversations with community leaders, representing the local mental health and substance use services, people with lived and living expertise, Indigenous organizations, city staff, members of local government, as well as various community members. And we know that this will serve to strengthen relationships as well as build communities' trust in the PACT model, in addition to creating opportunities for community buy-in and ownership, recognizing that community-led teams really are the best fit to provide emergency mental health care response to people in community. So the next bit is the mental health and well-being of staff, which was briefly touched on. This is important in recognizing how a robust training curriculum, as well as providing ongoing clinical supervision, ensuring that teams are able to build capacity as they ramp up to 24/7 to really protect the mental health and well-being of staff as they engage in this challenging work that can be extremely emotionally kind of draining and take up a lot of time. And so we want to protect their health and well-being so they can continue to do this work. And that requires us to look into some provincial standards of how teams across the province, as they are building up, can really support their teams and their team members to protect themselves. So the next piece is on data collection and reporting. So we are looking at a provincial model, and so we are implementing teams in multiple cities across the province and seeing different lead service providers. So it's a privilege to be able to find service providers in each community that have deep ties to the people and the culture of that community. But that also means each organization itself comes with its own culture and established best practices. So in the case of data collection and reporting, we've identified an opportunity to adapt new infrastructure, including a shared database system and ensuring capacity to collect data at the same level across teams. So we want to make sure we have a sustainable and relatively easy process for our service providers. Also looking at multiple streams of evaluation. So whether that's monthly quantitative reports produced by the service providers, as well as mid and end of year reports, looking at having external evaluation reports that can assess PACT as a provincial service model, and as well as our effectiveness at meeting some of the intended programming objectives. So the last kind of big reflection is around systems integration. I won't get too much into it. Sarah really had gone through this earlier, but just looking at when you're able to call 911, being able to reach that fourth option in BC of mental health support, just to ensure that the right option, the right mental health response is able to be dispatched to mental health calls. And through extensive engagement with some key systems partners, we have been able to identify some of the complexities that need to be worked through and the collaboration and resources that are required. And so that's an ongoing reflection and learning that we're working through. And all of this is extremely important as we are going to be expanding and adding 7 new teams by 2024. We're thankful that the province has provided us with funding to be able to expand our 3 current teams to 24/7, as well as adding on 7 new teams across the province. And just in the nick of time, we just have this slide here. So if folks want to connect with us, these are the various ways that you can get in touch. We'll also be hosting an information session with our 3 service providers this Friday, June 16th, and more information can be found on our website. So with that, I just want to pass it over to CMHA Toronto. I'll stop sharing my screen here. There we go.
Thank you, Ebony. Give me a second to share my screen. Oops. Okay. Welcome, everybody. My name is Archana, and I am from CMHA Toronto. And so I'm here to talk to you about Toronto Community Crisis today. And specifically, we are running this in the northwest area of Toronto. So in terms of, oops, sorry, I don't know why I jumped. So in terms of the context and where this program really came out of, so it came from City of Toronto's Police Reform Initiative, and there was this need to have an alternative response that's different from a police response to people experiencing mental health and addiction crisis. You know, and as well, considering sort of the historical pieces, we really wanted to create new program that reduces the harm that disproportionately affects Black, Indigenous, racialized, 2S LGBTQ+, and any other marginalized individuals that may be experiencing a mental health or addiction crisis. And so during this time period, there was the approach that was, it was a very intensive period of community engagement and research and getting the feedback from the community regarding putting together a service such as TCCS. And so there were 33 roundtables with 500 participants. There were some surveys that went around that had over 6,000 plus responses. And as well, we consulted some experts in the community and reviewed 53 other crisis models throughout the world and to see what aspects of these models would work best for our context here in Toronto. In terms of our, in terms of our principles of care, so our services are really grounded in the needs of the service user. So it is consent-based service. And so we're really taking into consideration the history that they come with, some trauma that might be there, their cultural pieces, maybe religion, all the different pieces that make someone unique, and that could be that would be important to the situation where we're attending to the call. There are also multiple pathways that people can access the service, so they can access it either through 911 or 211. There's also clear pathways for complaints, issues, and data transparency. So I will share my contact at the end of this presentation. So one way to provide feedback or discuss anything is by reaching out to me. You can also reach out directly to 211 as well. Some people have put forward complaints that way as well. The other piece in terms of our principles of care is that we are harm reduction based and trauma informed. And so what this essentially is speaking to is that the team is trained in harm reduction approaches. So in providing harm reduction education and providing tools and clean kits for people to use safely, as well carrying public health supplies. So, things like condoms, dental dams, lubricants, carrying all of those types of supplies as well. And then, as mentioned, the team is trauma informed. So really having this understanding of the prevalence of trauma in the community that we're supporting, as well, what trauma responses can look like, understanding those historical pieces of, racism, discrimination as well. In terms of our service, it is a 24/7 service, so it runs 365 days of the year throughout, even on holidays, evenings, weekends, we're open. As mentioned, it is a voluntary and consent-based service. So the team puts in a lot of effort here to receive consent and to really build that relationship and connection with the person that's in crisis. So sometimes, when someone is experiencing crisis, and we're also a new service, people are not aware of who we are and that trust may not be there. So the team, is very intentional about introducing who they are. They'll say what organization they come from, their name, and their role on the team. They'll also speak to the service, so what we can offer, so that the person can make an informed decision around their care in that moment. We do serve clients that are 16 plus. That being said, we do get calls from families where families are in distress, and there may be a loved one, or a sibling or a child that is under 16 present in the home. We're happy to connect them with additional supports for that age category. As mentioned, trauma-informed and harm reduction-based. And so that's really in our approaches that we take, making sure that, we're not taking a coercive approach. We're being mindful of our body language, our tone of voice, and really creating that safe environment and non-judgmental approach. As mentioned, people can dial through 911 or 211. We're really trying to promote that 211 line, again, to reduce that harm, right? With 911, what we've been noticing, and this is something that we're working towards and correcting, but sometimes what happens when dialing through 911, police are also being called. And so you might have two teams arriving on scene. And so for this reason, we're really encouraging people to dial through 211. But that being said, there's no wrong door. You can access it through either way. It is a mobile crisis team. So we do drive vehicles that are branded and that say Toronto Community Crisis on them. We can meet people wherever they're at in the community. So whether they're living at home, maybe they're precariously housed, maybe they're living in a shelter or a park, we can meet them wherever they're at. We're also able to transport them to wherever they need to go. So if they need to go to a hospital, for example, to stay safe that night, we're able to transport them to hospital or various other locations, so whether it's a shelter or a friend's house or a family member, what have you. What is also unique about our project here at CMHA Toronto is that we do offer post follow-up crisis. So there are many crisis services that exist in Toronto. And what's sort of unique about this is that everyone receives a follow-up call within 24 to 48 hours. And in that call, a case manager is determining, is there consent? Does this person want follow-up services? What are some of their goals? What are some of their needs in this moment? What are some immediate needs that are coming up for them? And they will sort of determine whether they stay on our caseload, if they will receive case management through us or through one of the partnerships that we've created with the TCCS project. And lastly, in terms of creating a safe space and safe support, we are really adapting our services to the different cultures, languages, really adapting our approaches to those different views that might come up, different beliefs, stigmas, sometimes they are around mental health and addiction. So really working within those boundaries and however the person identifies, really connecting with them on that level. These are the different call types that we attend to. So we attend to calls that are classified as well-being checks. This was predominantly being done by police before a service like this was in place. And so this could be, you're concerned about somebody, you haven't heard from them in some time, and you want the team to check in on them. We do attend to calls that are thoughts of suicide or self-harm, and it could be beyond thoughts of suicide. The person might have, might actually have a plan. So the team is actually trained to manage, to assess suicide and self-harm, and to create safety plans around that, and how to keep that person safe in the moment and in the next days to come. We tend to people or person in crisis, and we've left this general for a reason, right? Because people can be describing crisis in many different ways. Again, this could be because of the language or their culture, right? Each person can define what crisis looks like for them. And we were very, very intentional about this because crisis can also be a number of different factors, right? It could be one of those social determinants of health, right? You don't have a place to live tonight, or you don't have food security, and that's causing crisis. We do direct follow-up from police. So if police are attending a call, they're recognizing there may be some mental health or addiction related issues there, they'll flag it for our team so that we can co-respond or support even after. We do direct follow-up from ourselves. So for example, we use this in safety planning. If someone came to us, maybe they were having thoughts of suicide in the moment, part of our safety plan could be that we are keeping this person safe in this moment, but the team has agreed to check in on them in 3 hours. So we can do that follow-up directly from internally within the team. And then lastly, we do attend to calls that are disputes in nature. So because we don't attend to calls that are violent in nature, disputes would just be sort of verbal in nature. This can look like, you know, a landlord and a tenant that are maybe in a dispute, or a mom and a son that are in a dispute, and someone is experiencing a form of mental health or addiction in that call. So we're happy to attend those calls and support individuals. This is sort of speaking to the operations and what happens behind the scene versus on the scene. So I'll speak to what happens behind the scene first. So on any given shift, we always have 3 crisis workers. And so 2 crisis workers are out in the community supporting the individual. And then we always have a crisis worker that's at our home base. And what this individual does is they're monitoring the screens. They're checking for the calls as they come in, as they're coming in. They're triaging, and they're looking at the different levels of maybe priorities based on how the calls are coming in, and triaging based on that. They're also supporting the 2 crisis workers that are out in the community. So, you know, maybe an individual's needing shelter space, and instead of the 2 crisis workers being on hold with access intake for 30 minutes or 40 minutes, this person that's sort of in the background can do that type of work and coordinate all those support pieces needed for the individual. So this is a very pivotal role for us. You know, this is also done in a way to safeguard and to catch anything. So for example, we only have 1 team out at a time. So there might be a call that comes in where the person is experiencing suicide in this moment, and we're not able to get to this call maybe until 2 hours from now or 3 hours from now. It doesn't really make sense for that call to stay with us. So what happens is the access facilitator, or the person that's sitting at the table, will place a call to that client, assess the situation, and based on that conversation, what they can do is send this call back to 911. They can say, hey, you know, our team is not available until the next, you know, set of hours. We're concerned about this person's safety, and we think that they need to be seen sooner than later. So then we're able to safeguard calls in that way as well. On scene, so the 2 crisis workers, this is what you can sort of expect of how they will show up. So we're always in plain clothing, and you can see here in the picture, our clothing will have our logo on it. So it'll say TCCS. On the back, it'll have some of our partnerships that we have. We also carry our ID badges. So this is mandatory for us to carry on scene. It'll say what team we're from, that we're part of the TCCS team, our name, and our role on the team. We have to be able to be identifiable to the community. We do address who we are, our names, and we disclose that to anybody that we're meeting on scene, including other first responders. We do carry these 2-way radios, and this is just to essentially help the team communicate with each other in a quick manner. So this helps them stay connected with the access facilitator that is at our home base. It also helps us to communicate with 211 as calls are coming in and we're in the community. We do go out in these company vehicles that are branded and say TCCS Community Crisis Service on them. You know, there's some lessons learned here as well. Initially, when the program launched, you know, with good intentions, we thought it would be better for us to go in plain clothing, clothing that wasn't identifiable to TCCS, and as well, you know, unmarked vehicles. And this actually created a lot of mistrust or concerns for the community. And we heard them when they said, you know, how do I know who you are, right? You're coming in this unmarked vehicle or unmarked clothing. I don't know if you're the police or maybe somebody else. It would be really helpful for us to know who you are and be able to spot you right away. So we had to switch our approach and listen to the community. And so we went to this more visible option. In terms of confidentiality, you know, we are bound by P-HIPAA, so we do not disclose any personal health information when we're on scene with other responders. If there are safety concerns, we'll share overarching details and safety concerns. For example, if someone has disclosed to us that they can get triggered by police presence, and we know that police are arriving on scene, we want to give them that heads up, like, hey, you know, just so that you're aware, you know, your presence can be triggering for this person. This approach might be best. So really trying to navigate those on scenes to reduce that harm that someone may experience. And, you know, we explain to the service user as well as other responders on scene that we are bound by P-HSJCC. It is a multidisciplinary team of crisis workers. So we have, everyone is trained as crisis workers, and I'll speak to sort of the training that we have on the next slide. But just so that you're aware, we have different disciplines on the team. And the reason for this is, you know, we really feel that it really complements one another. We really bring different expertise and knowledge to the field when it is a multidisciplinary team. So we have mental health crisis workers, concurrent disorder crisis workers, so people that are trained in addiction and mental health, nurses, youth crisis workers, Indigenous crisis workers. As well, we have a very large team of peers. And this has been such a great value to the team, having people with lived experience on the team. It's been such an easy way to connect with the community, really to build that hope and foster resiliency, and to build that relationship in a very quick and easy manner. In terms of our skill set and what we bring to the table, so everyone has some sort of background, either training or experience in community mental health, addiction, and harm reduction. The team is trained in adapting our interventions to the different diverse groups that we're meeting with. So always using a non-judgmental and anti-oppressive lens. We do have public health skills. So, you know, identifying those, if we're seeing them on scene, as we're arriving to someone's home, providing crisis intervention, case management skills, being able to de-escalate the situation, really being in tune to people's, you know, different cultures or, you know, beliefs that they may have, and really adapting our approach to that as well. Obviously being trained in suicide risk assessment, crisis prevention strategies, overall safety strategies and safety planning. As mentioned, we do have a large team of lived experience, and this is such a great value that we bring. As well, we're trained in emergency skills. So for example, if we're attending to a call and someone is actively overdosing, we're able to engage in CPR or first aid, whatever is needed, and access EMS in the meantime. So this is just some of our data. This is just in our first 6 months of since the program launched. This is data that's from all 4 anchor partners. So CMHA is one of the anchor partners that is doing the TCCS project, but there are 3 other anchors in the City of Toronto that are also doing the project in various different areas. And so this is data that's collected from all 4 anchors in the first 6 months. And so you can see in the first 6 months, we attended to 2,489 calls. And, you know, our call volumes have actually dramatically increased since the first 6 months. And, you know, our call volumes right now are in the 8,000s or about 8,000. It's not there yet. So in the first 6 months, 63% of calls were coming from 911 and 23% were coming from 211. And since then, actually, there's been a change. We're actually seeing this to be about 50-50. So 50% is coming from 911 and 50% is coming from 211. 78% of calls within the first 6 months that were coming through 911, we were able to divert away without having any police involvement. So we're really happy about that number. Of all the calls that we attended, only 2.5% needed police attendance, and only 1.7% needed ambulance attendance. And this is, I think, one of my last slides here in terms of our follow-up services. So as I mentioned, everyone gets that follow-up call within 24 to 48 hours. And these are some of the supports that we do have access to. We've subcontracted some of our funding to these partners. So Addiction Services Central Ontario, Black Creek Community Health Center, Black Health Alliance, Yorktown, CAFCAN, Jane and Finch, and Rexdale. They're also part of a collaborative. So they oversee our project and they make sure that we are committing to a service that makes sense for the community. And so they're really governing and overseeing the project as well. And through the subcontract, as I was mentioning, we have access to, short-term case management, RAM clinic, addiction supports, homelessness supports, and various other supports. So, we're almost a year into this project in July, and some lessons that are learned and that I'll share in this group is that it was really important to have sufficient technology to meet the needs of the program. So having, screens and having sufficient computers or even technology in the community that we can use to really ease the work of the crisis workers and to reduce burnout. It was really important to have secured referral pathways. So to have that ahead of time before, as clients are accessing our services, knowing exactly where we can refer them and how to access that support. The other lesson learned here was, having resources even within the crisis work itself. So things like considering the vehicle that we use, right? Is our vehicle good for all 4 seasons, right? We have some pretty rough winter months sometimes, versus also things that we had to consider, having a leased vehicle versus an owned vehicle, right? What are the differences there? We weren't able to make modifications to our vehicle if it was a leased vehicle. What do we have as engagement, right? How can we engage with the community and build that trust? So do we have gift cards to distribute? Do we have things to keep people out of the cold or out of the heat? So thinking about those resources was really important. And then a key learning as well is that it is really vital and crucial to have ongoing training for the crisis workers as well as the follow-up team. We're dealing with really complex situations and a lot of diversity, and we want to be equipped. And so ongoing training is needed, and not just sort of in the beginning as people are being hired, but throughout their journey as a crisis worker. And that's it. Thank you for listening to my presentation. My contact is there as well. So as I mentioned, if you have any questions or concerns, you're more than welcome to reach out to me directly. If you do access the service yourself, you can also voice any complaints directly through 211 as well. Thank you.
Thank you very much. We're going to start going through the questions, but because we're very pressed for time, I'm going to deviate from what I usually do, which is to go through the questions generally in order. And I'm going to combine, since we have a lot of questions that sort of overlap each other, I'm going to ask some of the questions that can be combined, since there's a lot of interest in those overarching issues. One of them that was asked a fair number of times has to do with the safety of the crisis response teams that are responding to these calls, both in terms of physical safety and psychological safety. There were questions asking about everything from do they wear vests to things like re-traumatization of the crisis response workers. So I'll ask that to both of the teams presenting, if you could respond to those.
Yeah, I can speak to it on my end. And so in terms of Trevor, I hope I heard your the entire question. It was a bit quiet on my end. In terms of
Sorry,
safety,
I'll try to yell.
In terms of safety, our staff are just going out in plain clothing, like the ones that I showed in the slide deck. They are trained in safety, so they do get physical safety training. So how to assess the environment, how to be mindful of certain things as they're walking in into a new environment and connecting with people. So they are trained in that. They're also trained in crisis prevention intervention. So they know how to retract when the situation is escalating, maybe, and it's no longer safe. They will just leave the scene or retract from the scene. And there's, a bunch of other safety elements that are sort of tied into it as well. There is a screener that's done from 911 and 211 as callers call in to sort of assess what the situation is, what the background is, if there's somebody else there with you. So they do ask some safety screener questions over the phone as well.
And I'll just add on our end, so we're responding to mental health calls. So our teams, we're not responding to calls where there's a weapon. And when there's mental health calls, that just requires a mental health response. And so our teams, they don't wear protective vests. They have, as Archana said, their situational awareness training. They do go through an assessment to look at safety, and they are trained to continue to assess safety when they're on the scene. And then looking at some of the kind of psychological safety of the staff themselves, they do debrief, there's clinical supervision, they have overlapping shifts. They go through a lot of training to be able to protect, I think, like their mental health and psychological health as well, which is extremely important.
Okay, great, thank you. Another question or series of questions that came up had to do with one, are these teams considered first responders? And I'll combine that with a couple questions that came up regarding your relationship, your working relationship, and how it goes in terms of relating to police.
Yeah, on our end, we did have to build a relationship with police. There were calls that we were attending together, co-responding on scene together with. So we needed to be really clear about each other's protocols. And so there was a lot of education that was provided to Toronto Police around our approach, what they can expect from us, and what our objectives are for the program. We also had to develop a relationship with each individual division that we are responsible for. And with that relationship building, what that allowed us to do is, if there were concerns on scene, there was a sense of accountability. We can take it back to leadership at Toronto Police to voice some of those concerns and say, hey, we noticed this happen, so that it could be addressed in a meaningful way and in a collaborative way. Collaboration is needed with Toronto Police, because I think the reality is that there are times where we're going to be co-responding together. And in order to keep everyone safe, I think that relationship building was a crucial part of that.
Yeah, and for our teams, so they don't have first responder designation, but it's something we are currently investigating. We know that does require specific training, but that's something our teams would definitely be able to complete. And, our teams are in different cities across the province and will be expanding. And so the service providers come in with existing relationships with police and fire. And we've seen that we've been able to receive referrals from them as they learn about their services. So, teams individually do engage and build relationships, because as Archana said, that is an important piece. And so that's something that teams do keep in mind, as they're engaging in community engagement and building those relationships and trust, is explaining, what PACT is, that we're just taking those mental health calls. So, police are able to respond to the calls that fall within their mandate. Sarah, did you want to add anything? Or Erin?
Okay. Then there were some questions regarding how you measure the outcomes of your program and how you measure success ultimately of your programs, in terms of not just diverting from police, but the outcomes for the clients themselves.
That is a really great question. Maybe Erin, I'll let you answer that one.
We will. So BC here, we're in early days, as mentioned. So what we are doing, we do monthly reports right now in the early days of not only diversion, but follow-up. All three teams are active in follow-up care as well. So doing a bit of measurement there. We will quite in the next, over the summer, we'll be releasing a 6-month report that will tackle some of those questions being done by a third-party evaluator. We're also currently in a request for proposal phase to hire a third-party evaluator to take on not only the 3 existing teams, but to do, and their focus will really be around quality assurance, because we have so much of the quantitative data that's coming in monthly from the 3. But this evaluation, the more fulsome evaluation, will be around quality assurance, not only of the service providers and of the service that they're providing and looking at those client outcomes, but also of us, CMHA BC, as kind of the funder and the contract holder, and areas that we could improve. So it's a bit threefold. We do collect monthly reports with looking at some of those more quantitative diversion and client served kind of rates. We will be releasing a 6-month interim report looking at quality care. And then further on long term, we'll have this quality assurance evaluation that we're just in the process of selecting who that third party vendor will be.
Yes, and on our side with CMHA Toronto, we report data monthly to the City of Toronto as well, and they've partnered up with CAMH to do the sort of evaluation side of things. So everything is reported to them, and in terms of the program objectives, that was created collaboratively with community advisory groups, as well as the different anchors that are sitting at the table. So the first 6 months, the focus of the evaluation was really on implementation. And so I believe for the 1 year, it's looking at sort of the service itself.
Yeah, I was just curious as to whether you consider what you consider success, basically, for your clients. You know, and what. Basically, do you get a lot of callbacks to the same clients, for instance, whether you're measuring things like that? Then the other question that came up, it has to do with your resources. Do you find that you're getting more calls than you can handle?
So just with respect to that last piece, our teams have been very kind of cognizant in how they kind of are scaling up and looking at capacity and being very careful to make sure that, you know, they are able to respond to the calls that they do receive. And so far, they have not seen that, you know, they've been having to turn away any calls, which we're really grateful for. And then some of what we are looking at is some of the data that, you know, the teams are reporting that Erin spoke about, is looking to see if we do have callers, you know, calling back, or, you know, repeat callers, and seeing some people call again. I think an important piece is being able to support people doing safety planning, you know, having that 48-hour follow-up piece as well, to ensure that they are connected to supports that they might not have a plan in place, so they feel more supported and aren't in a situation where they're constantly needing to call due to being constantly elevated in crisis. So that's a piece that we definitely look at, and wanting to kind of reduce that state of constantly being elevated for people. Erin, is there anything else you wanted to add?
Yeah, and just to add on, that's been what I think for the existing teams and future teams, something that the service providers and us have been really cognizant of. We don't want PAC to turn into the service that no one could get a hold of and no one could reach. And so I can look at the example in Victoria here, for example, where they're getting high volume calls, and they have a very high physical response rate with high acuity. And what they have a position that's a dispatch position, so not impacting the teams. And what they've found, their response rate, for example, is they can be on site within 8 minutes on average to attend to one of their calls. And they're also getting calls that that would have gone to a co-response team, but the people are unable to reach the co-response team. So they're reaching PACT instead, and PACT is being dispatched instead of a car model or insert. So that's right now, but again, knowing we're early days, we're not seeing that these teams can't access in a very timely way at the client that's being called.
For TCCS at CMHA Toronto, we are also getting very busy, but we haven't had to turn away calls yet. And then the City of Toronto is also looking at expansion, hopefully by next year, to all of City of Toronto. I did drop a map in the chat, and you can see there's 4 different pockets where currently TCCS is live. There's a lot of white on that map, and that's where TCCS is currently not live. And I think so the hopes is that will the City of Toronto scaling to be citywide by next year.
Well, we're out of time, unfortunately, but thank you, everyone. And thank you, everyone, for attending. Thank you to our presenters. This was great. And I love these crisis response teams, the non-police crisis response teams. I look forward to seeing a lot more of them. And thank you, everyone, for attending.